when it comes to rehab, we're pretty much all dealing with motion, right? And we're either moving them for themselves, or we're moving them, or we're having them move themselves. Majority of what I deal with is me or them moving themselves. From there, where do we go? We either go to the area of injury, which is traditionally what we all expect and have been brought up with.
Mm-hmm.
Or the little known but faster producing results is actually going to not the area of injury. And when I say area of injury or quadrant of injury, I mean, if somebody's treating your shoulder, they're going to do the neck, the shoulder, maybe some ribs and thoracic. But they're so highly likely not to be going over on this side or down the leg, left leg, or the right leg. And there's a reason that actually, if they would, things work quicker. So with that said, you can go into injured area or not the area of injury. 98% of the people don't know about this over here, that it works, and it works very quickly. From there, this is the really essence of it. You can go into restriction,
Yes.
whichever one of those you choose, or into ease. What's causing that to happen? Tissue of the body can only do one of two things. Any of the tissue, whether it's viscera, whether it's nerves, whether it's organs, whether it's fascia, even whether it's bone, it can lengthen or it can shorten, compress or decompress. That's it. So when we go over as traditional therapists, that majority of the time you'll have is that when you lengthen something and it doesn't like it, it produces I don't like that. So instead of lengthening, so what we end up doing traditionally is continue to lengthen stuff. We try to fix what doesn't lengthen by lengthening it more.
Yeah.
Instead of, hey, or giving up. So most of the time you'll go from one clinician to another clinician to another clinician, but they all don't realize, even they may be doing what is termed a different technique, they're all still going into restriction. So what we do is we actually go to shorten. It looks like we're treating other parts of the body, but we're really shortening the injured area. So if I can't lift this up,
Yeah.
if I think about it, from my fingertips to my toes on my right mid-axillary, my side, something says I don't like it. Even a joint may go, I like going this way, I don't like going this way.
Right.
And so all we have to do is, okay, if we go into restriction, do the right side, into restriction, see if it works. Do 2 sets, see if it works. Then, if it doesn't, if we stay within the idea of restriction, why don't we go to the trunk and lengthen it and see if it works? And then we could go to the leg and kick it across, which lengthens the IT band.
Right.
Now we've really lengthened to see if lengthening is really going to work. And it may. I'm not against lengthening in any way, shape, or form. It's just part of the entire umbrella. What we do is we'll come over here and we'll lift this arm up, which makes it look like we're not treating this side. But by lifting this up, it's shortening over here. So we'll do 2 sets and see if it works. And typically it works faster, and it works. We're sitting there. Or where you shorten this way over the trunk. We only deal with arms, trunk, and legs, no matter what you come in with.
3 things, right?
3 things, that's it. You come in with jaw pain, I'm still doing arms, trunk, legs. So we shorten over here, right? And do 2 sets, recheck. And then we can shorten the IT band by lifting it out into abduction, if you will. Do 2 sets, see which one works the best. So there's all that possibilities, but really all we do and what we do is we just test motion, find out what works well, find out what doesn't work well. We track what doesn't work well, and we just pick any one of those yummy things to treat it. So I don't care what walks into me. I will do a scan of the body, motions, remember what's yummy, record what's yucky, and I will start every single person with a twist to their yummy side. Now, if they don't have a yummy, I'll go to another body area or another motion. And that's the essence of it. So all I'm doing is taking blinders off of people to go, well, that's too damn simple, Tom. Right? I know. And that's just it. Like most people pull back and go, Well, therapists and clinicians have a harder time grasping because we've been educated so much into restriction, but we don't even know that. So I can take somebody and I'll say to them, I said, look, if 100 PTs, physical therapists, chiropractors, I don't care who it is, DOs, are going to treat the right knee, and I'll have you answer this because I answer it in my seminars all the time. So if I have 100 clinicians, they're going to treat a patient with right knee pain. How many of them will start with the right knee or the right leg? Here's 100%, 90, 80, 70, 60. How many?
I'd say about 100%.
Yes, very close. You know, what I typically get is 80% and above. Okay, cool. That's our expectations. So we know that's predominantly what's done. So our whole career, we spend time in that quadrant of injury. Now, let me ask you this. And you're a DO, so this is perfect. If I go and you're learning how to do a joint mode, you were taught to move the joint around and find what? Where it's most what?
You look for restriction and you look for ease of motion too.
Good, awesome. Now, this is good that you said that, all right, because it's a kind of a counter-strain philosophy, but we won't get into that. So what percent of clinicians, if they find out anterior to posterior is the most restricted, what percent will begin treatment anterior to posterior?
I'd say about 80% of them.
Good. So let me tell you, or ask you, like in school, we were taught to find the most restricted and treat into it. Awesome, fine. We should have done 2 sets, saw what the result was, and then gone into what were the easiest, and then gotten 2 results.
Yeah.
Okay. And because we weren't, our entire careers were spent over learning and feeling and getting experience into restriction.
Right.
Very little experience into ease. So when people see it being done, it's awkward and wrong.
Yeah, it's like, whoa, what are you doing, man?
Correct.
That's an interesting thing because it's I call this into the restriction will be direct method, and then into the ease is the indirect method, and it's like, yeah, we just kind of ignore that part.
Correct. Now, I'm assuming because you said direct and indirect, are you familiar with counter strain?
Oh yeah.
Okay. So counter strain is where one of the things I got my beginnings in. All right. So counter strain is there's a tender point and we're going to fold over that tender point. Well, when you're hanging out there and you begin to melt over that tender point, there's motion that occurs. And I noticed that. And I said, interesting. So we're moving, there's motion. So what if I went against it? All right. So I'm melting into this direction. What happens if I were to go the other way? Would I go like into this restriction? And I did. So you could literally, through counter strain tender points, or just through counter strain, this is a functional or motion-based counter strain.
Yes.
A tender point counter strain, it's motion-based tender point. And what's cool about it is you can give it to the person. So we do 7 rules. It's the recipe for chicken noodle soup, but it's for pain relief. And we give them 7 rules and they follow it for the other thing. They pick their exercises they want to test. They pick the exercise for the full body, 2 arms, 2 trunk, 2 legs, or something thereof. And then they pick an area of injury forward, do a couple motions to get more, motions in the area of injury. And then they start treatment. And the first place they start treatment is a twist, as long as both sides one of the sides is young.
Right.
And that's the essence of it. So my whole job really is to get people out of what they've been comfortable with and give them experience into that other side.
I hope you enjoyed this episode of the Best Medicine Podcast with Bradley H. Werrell, DO. Don't forget to hit like and subscribe below, either over there or over there. Also, if you're interested in a medical consultation with myself, there's also information below.